Good morning, everyone. I'll try to keep it very basic, and I thank Vishwesh and the team at Yashoda for inviting me here today. Thank you. I'll be talking about the basics of management of our bread and butter diseases, which is most important to a pulmonologist, and I think even all treating physicians, consultants would see these two diseases as the most common respiratory disorders in our clinical practice, which is asthma and COPD. And the problem with asthma and COPD is every year, once you start remembering the guidelines, every year they would change the guidelines. So as postgraduates and as practicing physicians, we must understand that every year they would, modify the guidelines, and you need to pick up what is new, because that is going to change the clinical practice and the way you treat your patients. So very, very briefly, I'll be taking around 10 minutes each, 10 minutes of asthma, 10 minutes of COPD. So, COPD and asthma are so asthma and COPD, there are a lot of subtle differences between the two diseases, but there are a lot of similarities between them. Now, COPD is a disease, which is classically seen in patients who are above age of 40. It's a midlife kind of a disease. Asthma is seen in usually as a, early onset disease. Most commonly you see it in children. There would be some amount of exposure to noxious stimuli in any patient with COPD, most commonly tobacco smoke, but then a lot of other risk factors have been identified. Asthmatics can also smoke, but usually smoking would not be a classical risk factor for the development of asthma. There would be a lot of comorbidities in your patients who have COPD, because these patients are going to be elderly patients, so you need to treat the comorbidity as well. Whereas your asthmatic patients would have comorbidities like allergic rhinitis, sinusitis, itching, urticaria, and that is what you need to look at. Airflow obstruction, classically, when you talk about COPD, you talk about irreversible airflow obstruction, and when you talk about asthma, you talk about reversible airflow obstruction. However, this is not true for all patients. There would be patients with COPD who have a reversible airflow obstruction, and there would be patients with asthma who have an irreversible airflow obstruction. So, whether they are a similar disease, whether they are a different disease, where there's an overlap between these two diseases is still a matter of debate. However, what we do know is that there are certain differences and there are certain similarities between these two diseases. We need to work up every patient according to their own merit and treat them accordingly. So I'll first take on COPD. Every year they change the definition of COPD. This year the definition is really good because they have highlighted at a lot of new points. First things first, it is a heterogeneous lung condition. They say it is heterogeneous because the clinical features for all patients are going to be different. The risk factors for all patients are going to be different. The way patients present to you is going to be different. The amount of lung or the area of lung which is going to be involved in every patient is going to be different. And that is why this is a heterogeneous disease. One very important point that they have pointed out this year is they have labeled multiple areas. When we were students, COPD or obstructive airways disease, it was obstructive airways disease. And when they talk to us about the pathophysiology of COPD, they would talk about alveolar damage, they would talk about emphysema, and on one hand, they would say that this is an airway disease. So a lot of students would get confused, but now this year, they have said that COPD, because of its heterogeneous nature, can involve the airways, can involve the large airways, cause bronchitis, can involve the smaller airways, cause bronchiolitis, it can damage the alveoli and cause emphysema, and the damage that it causes is often persistent, progressive, and probably irreversible. Also, something new which has happened this year is that they have come up with a term called pre-COPD. Now, when it comes to diabetes, when it comes to, hypertension, we've been talking about pre-diabetes, pre-hypertension for many, many years together. However, now with the Goal 2023 guidelines, we have something known as PRISM, which is a surrogate for pre-COPD. What this is, I'll come to a little bit later. So we all know there are multiple risk factors for COPD. Age above the age of 40 years, it has been brought down from 50 to 40. History of chronic smoking, exposure to biomass fuel, which is very, very common in our country, especially in North India. Occupational exposure, recurrent lung infections, long-standing asthma, air pollution. So now if you look at the GOLD COPD guidelines, they have said that all these are risk factors for the development of COPD, and this is something new in 2023, that they have started talking about other risk factors of COPD rather than smoking. And so they have come up with this taxonomical classification or a nomenclature for COPD. So someone who has an alpha-1 antitrypsin associated COPD is going to be called as COPD-G or COPD genetic. Someone who has a small lung to begin with, someone who was born as a low birth weight baby and then had severe asthma, persistent asthma, and has developed COPD as an adult is going to be labeled as COPD-D, which is COPD due to a developmental disorder. Someone who has developed COPD due to pollution is going to be COPD-P. There used to be this term called asthma COPD overlap syndrome, ACOS, ACO. Now the term has been changed. It is now COPD-A. If you cannot find out the reason for the COPD, it is going to be COPD-U. Also something which is very, very important in our country, and thankfully for the first time Gold has included this, is post-infective COPD. A lot of our COPD, around 30% of the COPD that we see in India is post-tubercular, post-infective COPD. They have taken this into account. So from 2023, there is a new phenotype of COPD which is known as COPD-I. So for all residents, when you are working up your patients of COPD in your OPD or your IPDs, it is not just plain COPD now. You need to add one of these terms for the proper diagnosis, COPD G, I, A, T, whatever it is, so that you can sub-classify, and this is going to have therapeutic implications for your patient, and that is why Gold has come up with this. Now, when you're trying to manage a patient of COPD, and when a patient of COPD walks into your OPD, how are you going to manage this patient? So to manage this patient, there are certain clinical features that you look into, you need to take into account. There are certain features spirometrically that you need to take into account, and then you need to look at the number of exacerbations that this patient is having. Now, first things first, COPD unfortunately still is a disease which is diagnosed spirometrically. Your patient can have emphysema on a CT scan. Your patient can have emphysema on a X-ray. Classically, the patient can have cough, breathlessness, elderly patient who has been smoking all their life. But for the diagnosis of COPD, the spirometry has to be there, and the FEV1 to FVC ratio of 0.7 has to be demonstrated. Unfortunately, this has still not changed in Gold 2023 also. However, in the coming years to come, we will have newer diagnostic criteria for COPD, and that is where the term pre-COPD or PRISM has been introduced. So what is PRISM? PRISM is preserved ratio impaired spirometry. So you have a patient who has smoked all their life, the patient has cough, the patient has breathlessness, you have done a spirometry for the patient, the FEV1 to FVC ratio is still not less than 0.7, but look at the FEV1 values and look at the FVC values. If the FEV1 and FVC values are individually decreased, this is known as PRISM or pre-COPD. The trajectory of pre-COPD is said to be similar to patients who have COPD. So earlier, they would not ask you to follow up patients where you clinically thought that the patient had COPD, but the patient spirometrically did not have the diagnostic criteria for COPD. But in 2023, Gold has introduced the term PRISM. So any patient who has risk factors for COPD, who has features suggestive of COPD, but does not have a spirometrically proven COPD, you are going to label that as PRISM, and you are going to follow up those patients very, very strictly. So the classical classification criteria for COPD as of now is still for patients where the FEV1 to FVC ratio is less than 0.7, and then you look at the FEV1 value. And for the FEV1 values, you remember the rule as 80, 50, 30. Mild COPD, if the FEV1 is around 80%, between 50 to 80% moderate COPD, and if the FEV1 is less than 50%, severe COPD, FEV1 less than 30%, very severe COPD. So remember these definitions. So for classification of mild, moderate, severe, unfortunately, we still rely on spirometry, even though we know that this is not the gold standard for diagnosis. So if a patient of COPD walks into my OPD, first thing that I will do is I need to make a diagnosis of COPD, so I'll do a spirometry. The second thing I'll do is I'll label it, whether it is mild, moderate, or severe. The third thing that I'll do is I'll assess the patients of the symptom. Now, to assess the patient of the symptom, there are two scores which have been recommended. One is the MMRC score. This is something that I use because MMRC, NYHA, these have all been part of our training. Ever since second year MBBS, you know how to use this. And then there is a more comprehensive score which is known as the CAT score, but CAT score you cannot remember. So you need to have an OPD pro forma for this. So you can use either of these scores. So first, do a spirometry, make a diagnosis. Based on the spirometry, label them as mild, moderate, severe. The second step would be see their breathlessness, how breathless your patient is, either on an MMRC or a CAT score. Based on that, you draw a box. On the box, there is an x-axis and a y-axis. Early COPD is COPD A and COPD B. Earlier it used to be A, B, C, D. So A and B are patients where the patient does not have too many symptoms. The MMRC and the CAT scores are not going to be very high, especially for A. But E is on the basis of exacerbations now. So A and B are patients. The difference between A and B is the amount of breathlessness that the patient is having. Spirometrically, both A and B are not going to be too bad. The FEV1 values are going to be above 50%. Between A and B, the difference is going to be the breathlessness. So if the MMRC is high or if the CAT is high, but the FEV1 values are okay, the patient is B. If the CAT score is low, if the MMRC is low, the FEV1 values are okay, the patient is A. However, if the patient is breathless, the patient is having more than 2 exacerbations in a year, and if the patient is having any exacerbation which is landing them into the hospital, you need to label the patient as COPD E, and this is a patient who is an exacerbator phenotype of COPD, and the management of COPD is going to be dependent on where your patient is in this box of A, B, and E. And to make this box, again, I'll go back to it because this is very, very important. You need to have the FEV1 value of the patient. You need to have the MMRC or the CAT score of the patient, and you need to have an exacerbation history of the patient. And unless I have the A, B, E score for my patient, I would not be able to give them the correct therapy because the therapy would depend on where in this box the patient is going to be placed. So this is the A, B, E classification. So if there are any doubts, please ask me, stop me and ask me then and there. So this is how you would start working up your patients of COPD in the OPD. And how do you treat them? What are the goals of your treatment? The goals of your treatment are going to be, you need to relieve their symptoms, you need to improve their health, status overall, you need to improve their exercise tolerance. So for a lot of patients with COPD who are elderly patients, their complaints would be, I'm breathless even on going to the washroom. I'm breathless going to the temple, going to the market, leaving my grandchild to the bus stop. So a lot of these patients would ask you to decrease their symptoms, but a good physician is not only going to decrease the symptoms, they are also going to decrease the risk of further exacerbations. And this is something very, very important. The management of exacerbations in COPD is the key to the management of COPD. Even if your patient is not too breathless, but your patient keeps on having exacerbation, the patient keeps coming to the hospital every now and then, with every exacerbation, the lung function decline is going to be exponential. So a good physician is not going to only take care of the symptoms of the patient, but also prevent the exacerbations in the patient and also treat the, try to decrease the progression of the lung function decline in this patient. So the goal of COPD management is not only to decrease the symptoms, but also to preserve the lung function and also to decrease the exacerbations of the patient. So how do you choose the correct therapy? You need to understand that COPD is a syndrome. COPD is not something that involves only the lungs. COPD involves the whole body. The lung is at the epicenter of the problem, but you need to treat the whole body and you always need to treat the comorbidities in your patients. Very impressive Indian data shows that every patient, on an average, a patient of COPD, advanced COPD in India will have close to 5 comorbidities which are not associated with the lungs. The patient can have diastolic heart failure, the patient can have anemia, polycythemia, osteoporosis, atherosclerosis, diastolic heart failure. So the number of comorbidities in patients with COPD is going to be exceedingly high. And if you don't manage the comorbidities properly, you're not doing justice to your patients. The disease is going to have variable pathologies. Now we talk about treatable traits in COPD. We talk about individualizing therapy in COPD. So there would be patients who have an inflammatory phenotype of COPD, wherein you need to focus on anti-inflammatory agents. There will be patients who will have a more breathlessness or a dyspnea predominant variant of COPD, where you need to focus on the bronchodilation. So there is always this debate between steroids and bronchodilators. Look out for this asthma COPD overlap, which is now known as COPD-A, because a lot of these patients would need a lot of inhaled steroids and not just bronchodilators. And always remember, 50% of the treatment of COPD is non-pharmacological. Unfortunately, our emphasis is always on drugs. The patient is breathless. Okay, this drug is probably not working. Let me change your drug. No, you need to look beyond drugs, which is very, very important. So for all residents, summing up the pharmacotherapy, there can be anticholinergic agents, which can be short-acting or long-acting. There can be beta-2 agonists, which can be short-acting or long-acting or ultra-long-acting. There is something which is known as a combination of LABAs and LAMAs, which is not yet available in the Indian market. And of course, we have the good age-old methylxanthines and PDE4 inhibitors, inhaled and oral steroids, and N-acetylcysteine. So inhaled bronchodilators are the keystone in the management of COPD. Beta agonists can be short-acting and long-acting. Short-acting beta agonists are salbutamol and levosalbutamol. Longer-acting ones are salmeterol, formoterol, indacaterol, vilanterol. Anticholinergics, short-acting is ipratropium, long-acting tiotropium and glycopyrronium. So all postgraduates who manage COPD must remember the bronchodilators that are available in the Indian market. The emphasis now, the management is now shifting towards longer-acting bronchodilators. Earlier, our focus was more on shorter-acting bronchodilators. A lot of patients with asthma COPD would be on shorter-acting bronchodilators, but now our emphasis is changing towards longer-acting bronchodilators. So we are changing our practice from shorter-actings to LABAs and LAMAs now. So this is the COPD ABE diagram. What would you do? So COPD, the GOLD guidelines tell us that if a patient comes to you with COPD A is a patient where the lung function is preserved, the patient is not too breathless, the patient is not having too many exacerbations, you need to give them a single bronchodilator. Since standalone LABAs are not available, you need to give them a LAMA. The LAMA, which is anticholinergic or antimuscarinic, can be either glycopyrronium or tiotropium. What is group B? Group B COPD is a patient where the lung function is not too bad, the patient is not exacerbating too much, but the symptom burden is very high. The patient is very breathless, the CAT score is high, the MMRC is high. So in this patient, you need to give them a combination of a LAMA and a LABA. On the other hand, you have something which is group E COPD. The lung functions are bad, the patient is breathless, the MMRC is high, the CAT score is high, the patient is exacerbating. This is a candidate for triple therapy wherein you need to add LABA, LAMA and ICS, which is an inhaled steroid. So this is why you need to make this ABE diagram, because the management is going to depend on where your patient sits in the ABE diagram. And group E COPD is something which is very important, because now they want to distinguish it between dyspnea predominant group E COPD and exacerbation predominant group E COPD. Don't get too boggled or too confused by this. For all practical purposes, the treatment of group E COPD is triple therapy, LAMA, LABA with inhaled steroids. There are certain patients who are going to have exacerbations despite being on triple therapy. You can add low-dose macrolides, prolonged macrolides in these patients, roflumilast, which is a PDE4 inhibitor. But the practical therapy for group E COPD would be triple therapy. So now there is very good data which tells us that triple therapy in severe COPD, Trilogy trial, Loads of Trinity trial, all of these trials tell us that this decreases exacerbations, improves the mortality. So for all patients who have frequent exacerbations in severe COPD, you need to treat them with inhaled steroids. So what might work in COPD? We don't have very good data with macrolides, roflumilast, N-acetylcysteine, methylxanthines, lung volume reduction surgeries. All of these are expensive. We don't have very good data with this, but we are very fond of using it. What we know works in all patients with COPD, unfortunately we don't do it in clinical practice, vaccination. Talking about pulmonary rehabilitation, asking these patients to exercise, do yoga, smoking cessation, oxygen therapy in the right patients, and use of NIV in the right patients. So if your patient of COPD is exacerbating again and again, the patient is breathless, the patient is not doing too well, don't just focus on the pharmacotherapy, shift gears, go ahead, do something else for these patients, ask them to stop smoking, give them NIV if they have the right indications, give them oxygen, give them vaccination, and that is going to benefit your patient more than juggling with wrong pharmacotherapy, which is not evidence-based. So bronchial asthma, very, very briefly, asthma is an inflammatory disease. The crux of management of bronchial asthma is anti-inflammatory therapy. When I was talking about the management of COPD, the management of COPD was bronchodilators, LABAs, LAMAs, combination of LABA, LAMA, and inhaled steroids were only used in a certain subset of COPD. When you talk about bronchial asthma, it is an inflammatory disease. And to treat an inflammatory disease, you need anti-inflammatory agents. The best anti-inflammatory agent for bronchial asthma is inhaled corticosteroid. So inhaled corticosteroid is a controller medicine which needs to be given to all patients with bronchial asthma, depending, irrespective of what is the stage or what is the severity of their asthma. So controller medicines are the ones which take care of the inflammation. Inhaled steroids, oral steroids, leukotriene inhibitors such as montelukast, these are all controller medicines. And then you have reliever medicines such as salbutamol, levosalbutamol, beta agonists. So the management of asthma is not relievers, not bronchodilators. That is symptomatic management of asthma. The management of asthma is inhaled corticosteroids. And obviously, just like COPD, you don't want to just improve their everyday life. You want to take care of the exacerbations and you want to decrease the lung function decline in these patients. There is no role of SOS SABA now. So any asthma, mild, moderate, severe, no patient of asthma should go home with a blue inhaler or an inhaler which contains only salbutamol or levosalbutamol. We are moving away from reliever-only therapy now. And in early stages of asthma, which was earlier known as mild asthma, GINA step 1 asthma, where the patient is not too bad, before 2019, if you look at the GINA guidelines, the treatment was SOS SABA, 2 puffs of salbutamol or levosalbutamol. We are now moving away from this. Now we have realized we need to be smart. What is smart therapy? Smart therapy is early initiation of inhaled steroids and a drug which is known as formoterol. Why is formoterol smart? Because formoterol has a rapid onset of action and it has a prolonged onset of action. So the patient will use only one inhaler which will give him immediate benefit and is also going to cover the patient for the next 12 to 24 hours. So now the management of asthma, even early asthma, mild asthma, is initiation of smart therapy in the form of combination of ICS LABA. The inhaled steroid most commonly which is going to be used is going to be budesonide, and the LABA which is going to be used for these patients is formoterol. So every patient of asthma goes home on ICS LABA, which is formoterol with budesonide. When you're trying to manage a patient with bronchial asthma, it is always a stepwise approach. Every time a patient of asthma comes to your OPD, you talk to them about their daytime symptoms, their nighttime symptoms, how many times they're missing their school, college, office, how many times they're getting up in the night, how many canisters of their SOS therapy are they using, and then you increase and decrease the patient on the GINA step ladder accordingly. And every time the patient comes to you, you need to, if you look at your GINA guidelines, there's a small chart over there. There are 4 or 5 questions, which are these questions only: daytime symptoms, nighttime symptoms, school absenteeism. Tick them, and if your patient is ticking too many boxes, your patient is uncontrolled, you need to step up your therapy. If your patient is doing well for 3 months, the patient is fine on 1 dose of inhaled steroid, you need to bring down or step down the therapy. Step up and step down of therapy in GINA is based on the dose of the steroid. So any physician who is trying to manage asthma must know what is a low dose inhaled steroid, moderate dose inhaled steroid, and a high dose inhaled steroid. This would depend on what steroid you are using, whether this is fluticasone, whether this is budesonide, whether this is mometasone. So whatever steroid you are comfortable with, I am most comfortable with budesonide, so I follow this. What formulation of therapy are you using? Whether you are using an MDI with a spacer, whether you are using a DPI, the dose of the mild, moderate, and the high dose steroid, low, moderate, and high dose steroid would depend on that, and the step up, step down would depend on that. So for a patient who's on a DPI device containing budesonide, low dose is less than 800 mics of budesonide every day. 800 to 1000 is moderate dose of budesonide, and anything more than 1000 mics of budesonide in a day is high dose inhaled steroid. All postgraduates must remember this table by heart, and this is what you are going to step up and step down with. So after GINA 2019, the guidelines for mild asthma or early asthma have changed. Earlier, step 1 asthma was SOS SABA. Now there are 2 tracks of therapy. Step 1 asthma. As soon as you diagnose asthma, I know you have been seeing this GINA guideline diagram ever since second year MBBS. As soon as you diagnose asthma, the patient has to be started on a combination of formoterol with budesonide. If by any chance you are giving your patients an SOS SABA, for example, if you are giving the patient SOS 2 puffs of say Astelin, salbutamol, levosalbutamol, that has to be backed up by a inhaled steroid. So even if the patient takes an SOS SABA, the patient should also take inhaled steroid with that. So the advantage of smart therapy is in one dose, in one inhaler, you are giving the inhaled steroid along with the bronchodilator. So the patient does not have to carry two inhalers with them. And that is why step 1 therapy, step 2 therapy is low dose inhaled steroids with formoterol, and all patients of bronchial asthma should go home on this therapy. So this is something which is very, very important. Earlier, we used to think that asthma is a disease of bronchoconstriction. Patients, would ask you that, why should I not use my blue inhaler? Why are you giving me a more expensive inhaler when this gives me very good control? Every patient, you need to tell them that we want to decrease your inflammation in the airways. Otherwise, the outcomes are going to be worse. And patients, tend to prefer the SOS inhaler because this used to be a low-cost inhaler. Now, thankfully, most of the inhalers are equally priced in India. So a lot of our patients now do get convinced to use the longer-acting inhalers. Also, never use the term mild asthma in front of your patients. Don't give them SOS SABA therapy because it has been shown that 30 to 30% patients who come to the hospital with acute asthma, a quarter of patients who die with asthma, a quarter of patients who get admitted with asthma are patients who were labeled as mild asthma. So don't treat mild asthma mildly. Don't use this term because the patient is not going to take their disease seriously. So every patient who has asthma, irrespective of whatever they are on the GINA scale, you are going to give them inhaled steroids with LABA, and never use the term mild asthma. This is now taken away from the guidelines because the patients are not going to use their disease or going to take their disease properly. And patients who are given SABAs alone, without the inhaled steroids, the airway inflammation is going to be persistent. Over a time, what happens is when these patients are chronically using their beta agonists, their salbutamol, levosalbutamol, the beta receptors downregulation takes place. The number of beta receptors that are left behind are not too many. There is a rebound hyper-reactive, responsiveness in the airways. There is decreased bronchodilator response, and this leads to poor outcomes. So I'm saying this again and again, all patients, whatever stage of asthma it is, are going to go home on inhaled steroids. So again, step 1, step 2 is more or less similar. All patients should be on ICS-LABA combination, which is for all practical purposes, formoterol and budesonide. If the patient cannot take ICS-LABA, the patient wants to take only SOS-SABA, you need to always add a inhaled steroid to these patients. Here, the GINA talks about a second track. There would be a certain, patient who will not agree whatsoever that they are not going to use an inhaled drug. The second line track here is the use of a leukotriene inhibitor, which is montelukast. Now, every patient with asthma should not be given montelukast. Montelukast is a second-line therapy which is to be given for asthmatics if they are not able to take their inhalers. There are certain special indications. A young asthmatic who has a comorbidity of, say, rhinosinusitis and which is uncontrolled, probably in these patients you can add montelukast. There is no rationale of combining montelukast with levocetirizine and the combinations that we have become so fond of using. It has no place whatsoever in the GINA guidelines. So early asthma, step 1, step 2 is ICS-LABA. Step 3, step 4, you need to increase the dose of the ICS. So if my patient was on, say, 400 mics of budesonide, which is low dose, in step 3, I would probably increase and my patient would be on a moderate dose of budesonide, which is 800 to 1000 micrograms. Any patient who requires more than 1000 micrograms of budesonide in a day is a patient who has a GINA step 5 asthma. This is a patient who should be referred to a specialist pulmonologist where they can phenotype the patient, where they can find out what is exactly wrong with this patient, whether this is Th2 asthma, Th1 asthma, work this patient up accordingly and treat them accordingly. So there are so many diagrams and so many confusions in the GINA guidelines. What you need to understand is that this is actually very, very simple. Step 1, step 2, ICS-LABA. Need to remember the dose of the steroid that you are using. If the patient is not very well controlled on, say, a low dose of budesonide, which is less than 800 micrograms, step up. The patient is now going to step 3 or step 4, wherein you are using 800 to 1000 micrograms of budesonide in a day. If the patient goes above 1000 mics of budesonide in a day, this is step 5 asthma. And at this stage, the patient needs specialist attention. The patient should be sent to a pulmonologist for phenotyping. So to summarize, obstructive airways disease, multiple factors are required for tailoring therapy. Phenotyping is the key. Every patient is going to be different. Gina Gold, they tell us that the disease is heterogeneous. Different compartments of lungs are going to be involved. COPD, the goal is to not only decrease the symptoms, but also to decrease the exacerbation risk. Inhaled steroids in COPD are only given to group E COPD, wherein the patient has advanced disease and the patient is a frequent exacerbator. In bronchial asthma, the goal is to preserve the lung function. We are moving away from SOS therapy. Controller medicines, especially inhaled steroids, are to be started early in all patients with bronchial asthma. Choose the inhaler device correctly. We have a different session on that. Always demonstrate the inhaler device to your patients and always remove the stigma that is associated with the inhaler device. So this is in a nutshell about the management of bronchial asthma in COPD. If there are any questions, I'll be very